Next in our webinar series, Let's Talk About Epilepsy Surgery, we have Dr. Elaine Wyllie from the Cleveland Clinic, who's honestly a titan in the world of pediatric epilepsy and pediatric epilepsy surgery, and she's here to discuss pre-surgical evaluations with us. Welcome, Dr. Wyllie.
Thank you so much, Ms. Jones. It is truly an honor to be here as part of this important program. I'm very grateful for the opportunity. When should we think about epilepsy surgery? When does this come into our conversation? If we're working with seizures that are continuing despite treatment with 2 or more medications, then sometimes we have to ask ourselves, should we keep trying medications? Should we try the ketogenic diet? Should we try vagus nerve stimulation? Or is there a possibility that surgery might even be the answer? Certainly, we won't think about surgery unless medications are not fully effective. But if they are not controlling the problem, then we usually ask ourselves where surgery could play a role, if any. And then we're looking for clues that suggest that the seizures are beginning from a single trouble spot in the brain. Is there a spot where the seizures are starting, a seizure onset zone, a trigger zone, or a pacemaker zone? Because theoretically, if we can confidently identify such a spot, then if we could remove it, we could stop the seizures. So that's what we're wondering about. Seizures that are continuing despite treatment with medicine, and then a possibility from clues that there might be one spot causing the trouble. And if those 2 things are in fact going on, then that should prompt an evaluation to consider the possibilities for surgery. It does not mean that we have decided on surgery or that you have agreed to surgery. It simply means that it's probably time to get a little more information to see whether or not it could play a role. Now, one question might be, how many medicines should we try before we actually embark on this journey to look for things? And we can tap back to some very important data that was collected and published in JAMA Neurology in 2018. It was almost 1,800 patients that were studied very rigorously. And this gives you a graph here. If you look, each of these columns represents a drug trial. So for example, if you take all of the patients, how many are seizure-free after the first drug is used? Of the ones who do not become seizure-free, how many then become seizure-free with the second drug? If those people don't become seizure-free, then how many become seizure-free with the third drug, and so on. And as you can see with the first drug, 45% of people become seizure-free right away, but there are some who don't. And so then we try the second drug, and it's another 28% will become seizure-free. Then with the third drug, it's about 23%, and it goes down. The next 3 drug trials will be 14 to 15%. 7th drug is dropping down to under 10%. And then by the time you get to the 11th drug, there weren't that many people in this trial that went to that many different drug trials, but there weren't any people who got all the way to seizure-free after that many drugs had been tried. And one telling feature is that of all the people who become seizure-free in this entire study, 71% of them became seizure-free after the first drug. So the first drug solving the problem is a wonderful thing to happen and a great result. Sometimes we can get our result with the second drug, and there are other people who will respond after more trials. But if you notice, those numbers are getting smaller. So what we're trying to weigh out is the chance for seizure freedom, whether we use more medications or whether we move to surgery. And even if you are thinking about just 2 drugs failing, you've got a 23% or less chance of stopping the seizures completely with the next trials. Not a 0 chance, but it's getting lower. Compared to with surgery, if surgery looks like a favorable option, then we usually are talking about an expectation greater than 50% likelihood that seizures would totally stop. And with some of our surgeries and some of our situation, it's often above 75%. So the big point here is that it's not that medicines are hopeless necessarily, but they offer so much less hope than surgery if surgery looks like a favorable option. So there are times when we're looking at epilepsy where seizures are fairly frequent and they're disabling and problems are definitely impacting the person and the family, And the odds of medicines working are just getting a little discouraging. And so we ask ourselves, of course, what if we were to look into a completely different approach? Could surgery be a game changer and be an opportunity for a better life? That's the equation we're thinking about when we agree together to look into surgery or to have a pre-surgical evaluation. It doesn't mean you've decided on surgery or that you're comfortable with surgery. It just means, you know what, why don't we stop a minute, pause, and before we try a fifth medicine or a sixth medicine or a seventh medicine, let's just see what other options we might have and then consider them carefully together. So I like to think that the issue of whether to start a pre-surgical evaluation should be relatively low bar, because we don't know for sure where it's going to lead, but we do have some clues to say that we should look. Once we get into that process, then we have some goals that we're trying to meet with our pre-surgical evaluation. Our questions we're asking are, can we identify a single trouble spot in the brain which is causing all the seizures? And is the trouble spot in an area of the brain that may be safely removed? Now, naturally, that's a very detailed sort of analysis, and we want to be sure, because brain surgery is something, you know, once you've done it, you can't undo it. So we want to be very careful about this, and that's why the testing has to be very thoughtful. Now, Ms. Jones, before I start a conversation about how we approach this, do you have any questions about our thinking of when to start an evaluation?
Well, I'm just thankful that you've said, you know, you haven't decided to have surgery as a parent. Once you decide that your child should have the first phase of the evaluation, we like to say you're just figuring out what all your options are. And we see so many parents that they don't even want to think about brain surgery. We're really, at least with these evaluations that you're going to talk about soon, we're just putting all your cards on the table. You want to see what the options are. So thank you for saying that.
I think it's very important. Surgery is frightening to think about for a parent, but doctors also are very much concerned. We don't want to, you know, what's our motto? Do no harm. So if we're pausing and looking into the possibility for surgery, it's no more than if we sit down and talk about what the side effects of the next drug could possibly be. It's the same kind of thing. We just want to get more information and then make a decision together with you. So to meet these goals, there are three pillars that really are the starting point. The first three pillars of the evaluation. I'm going to use this code word clinical features because I didn't know what was better. It's what we're doing in the office at our first visit. It's our history, our physical examination. If you've been to the doctor about a seizure problem, you know that a lot of questions will be asked. That's what we're doing when we're exploring what we call the clinical features. What is the underlying cause of the epilepsy? When did it start? How old is the person now? Is the physical examination normal, or are there some deficits, for example, weakness on one side of the body? What are the seizure symptoms? Because the seizures are actually electrical activity affecting a part of the brain, at the onset of the seizure, we're trying to get clues about where that is starting based on what the effect is. For example, if the first feature is some jerking of the right hand, then we know that we're going to be very suspicious about the middle part of the left hemisphere because of the way that seizure is evolving. On the other hand, if the first symptom is something visual, for example, seeing bright, sparkly lights or something like that before the evolution, then we're going to be thinking about the back of the head and the occipital lobe because that's where vision is. So you probably have been a part of this situation where the neurologist will ask a lot of questions about what the seizures look like. And that's why the doctor is being so careful, is they're trying to look for clues about where in the brain these seizures are starting. And this is one of the very earliest things that we're thinking about. When I meet a family in the clinic, and I know this is true for all my colleagues, when we're talking about the history and all of the details that come out and the questions in that initial visit, we're already asking ourselves, down the road, if this doesn't go my way, sounds like this might be a focal epilepsy starting in one spot. Maybe I can circle back to that, certainly not now. But I'm thinking about that all along. What are the clues about the epilepsy starting in a certain spot of the brain? Are the seizures stereotypes so that it tends to be the same spot every time? And if so, what might that mean for the future? We would still start with medications, but it's just information that we gather and park. But if we're coming back then to talk about the possibility of surgery, that information becomes very important. So interestingly, one of the biggest pillars of all is the conversation and the examination that we do at our very first visit. That really turns out to give huge amounts of information down the road. The next most important part of the pillar is MRI. Does the MRI show a spot where the seizures are likely arising? If we can actually see something on MRI that we know is the kind of thing that causes abnormal electrical activity to arise, and if we see it in one spot and it matches up with what we got from our analysis of what we'll call clinical features, the MRI matching with everything else that we have, that's becoming very powerful for building a confident case that we know the spot where the seizures are coming from. And then the next pillar is video EEG. Do the video EEG findings complement or augment the findings on MRI? In other words, if we already have a theory based on everything that we learned in the clinic visit, plus the MRI, then does the EEG match up with that? Or if it doesn't exactly match up, is it compatible with it? In other words, it doesn't take us off track. Sometimes the MRI doesn't show us what we want, and then the EEG becomes paramount because we have to use something to guide us. And sometimes that EEG will be the thing more than the MRI. But the MRI is truly powerful. And so starting with these three things, we can usually get a pretty good sense of where we're going. And then what we're thinking then, we're going to ask ourselves if the following are true. Seizures are persisting despite medicine. If that is a check mark and the medicines have been used well and they're not yielding good results, then that's number one. Number two, are we confident about the location of seizure onset? If that's the case, we feel like we have very strong evidence based on everything we've learned from conversation and examination and EEG and MRI. And if we think that that area that we're suspecting could be removed without causing new deficits, what I mean by that is any damage to any other function, that this area that we would like to remove is basically in a silent spot of the brain where the removal would not leave new problems in its wake, then if we have the following things, if all three of those issues are true, then we should seriously consider epilepsy surgery. We should talk further about it. Sometimes we go into the pre-surgical evaluation because we're wondering if it's a possibility, and sometimes we come out of the pre-surgical evaluation with the conclusion that it is not a favorable option. But if these three questions get answered in a positive sense, then we should talk, then we should sit down and we should consider the possibilities of that. Now, the next step, of course, is to think about the risks of surgery, and we obviously have to weigh that very carefully. The risk for surgical complications, and we have to balance that against the chance for seizure freedom, which of course would be the benefit. So we have to pull all of these things together to talk about the individual person who has had the evaluation. These are not the same facts for everybody. It has a lot to do with a very personalized approach. And when we're talking about the risks of surgery, we divide those into two categories: expected risks and unexpected risks. And the expected risks are based on the location of where we're planning to do the removal. If we're going to be in an area where we think we could remove that without causing any new problems, we're not going to take anything related to language function or motor function or visual function, if we're not going to be near anything that will leave a new problem behind it, then we would say that the expected complications of surgery are none. So we have to address whether or not there is any expected impairment from surgery in an important area. Obviously, it's much more favorable if the answer is no, there are no expected complications. But we also have to talk about unexpected complications, and these are the risks of neurosurgery that can occur in any situation. Unexpected complications are bleeding, infection, stroke, anesthesia issues, And of course, the neurosurgeon will be very granular and detailed about the percentages for this, and also the track record at the institution where you're considering the surgery. What is the complication rate, you may call it? Unexpected complications of neurosurgery for epilepsy now are very low, fortunately. We have very safe techniques now, and it's come a long way over the last several decades. And losing a patient to epilepsy surgery is very, very uncommon. And so, in fact, the risks of an unexpected complication are overall low. And one thing that is helpful to remember is that these risks, they are not zero, of course. Brain surgery is not trivial matter under any conditions, but the risks of modern epilepsy surgery are low, and they are counterbalanced by the risk of not doing surgery. And I think an important concept here is that if you're dealing with uncontrolled epileptic seizures with no serious likelihood that they will ever be completely controlled, then you're looking at a lifetime risk of epilepsy versus a shorter term risk of surgery. And so you don't have a risk-free option, sadly. And so that kind of helps us a little bit, I think, to understand and accept a low but not zero unexpected risk, because there is a risk to not doing it. And let's just review some of these risks of not doing surgery. I certainly don't have to tell any of you what those are, because you're living with this in yourself or a family loved one. But a lifetime risk for seizure-induced injury, ED visits, hospitalizations, this can be quite significant for some people. A lifetime need for high-dose medications with a risk for potential side effects. You know, that is, and some of these side effects are mild, some of them are annoying but not dangerous, and some are even, you know, pose a threat. So that's not a small matter. Often we'll need epilepsy medicine after surgery, even for a long period, but we can typically use much less and fewer numbers and so forth if we get a good result. And sometimes, especially for children, we can even get to the point where there's nothing. That does occur. And of course, there's a lifetime risk for SUDEP, a sudden unexpected death in epilepsy. And I know that this audience is familiar with that concept. 1 in 1,000 adults and 1 in 4,500 children succumb to SUDEP among those children with epilepsy or adults with epilepsy per year. So in a given lifetime, that risk is cumulative, and the risk for SUDEP in most studies has actually been shown to be higher than the risk for mortality with epilepsy surgery by a significant. As a matter of fact, it looks like epilepsy surgery is a way to reduce the SUDEP risk. So. Yeah. So I'd like to pause now, Ms. Jones, and please, you must have some questions about the point so far.
Well, I think some comments in that what our families see often is regression of skills, especially with infants and young children and babies. The children will start to attain certain developmental milestones and then regress or not attain them at all because the seizures are disrupting, you know, the circuits of the brain. I know my son is a multiple procedure child, and in between his second and third epilepsy surgery, they were revisions to hemispherotomy. I did not want that third surgery. And in that year that we were just not sure we wanted to do it a third time, he lost all his spoken words and has never spoken to us again. They're gone. So we like to say to families, you're really at an awful crossroads when you're starting to do this, but that lifetime risk of continued seizures for these children can be catastrophic.
Ms. Jones, you bring up such an important point. In pediatrics, that is so paramount. It is often equally of concern as the seizures themselves, is this terrible price that's paid with development. When constant seizures are occurring during phases of brain development, that's not the time we want to be causing these kind of problems. And you're absolutely right. Surgery can really change that process dramatically in our favor. So thank you for bringing that up. You're absolutely right. And sometimes people ask how, you know, what is the timing? When should we think about surgery? You know, how long should we wait? When should we do it? And my way of thinking about it, remember we talked about those 3 questions. Will the surgery be necessary? You know, are seizures continuing without drugs? Number 2, will it be effective? Do we know the area to remove with a high likelihood of success? And 3, will it be safe? Is it an area where the removal could be done without causing problems? My feeling is that once we answer all 3 questions as a yes, then that's the time to do surgery. There is waiting can only add to the burden and the suffering in between that decision and moving forward. So I think you bring up a very, very important point that's especially relevant in pediatrics. So at this point, I'd like to share with you a couple of cases that might illustrate some of these points about how we use the testing in the pre-surgical evaluation. And we're talking about the 3 pillars, the clinical details that we get in the office, the MRI and the EEG. I'd like to share Nicholas with you. We met him at 13 years of age. He had a stroke at birth on the left side of his brain. And I think you can see this is a view where the eyes would be in front, down a bit lower, the ears would be on the left and right side. So it's a parallel plane to the floor and the ceiling. And you can see with this that on the left side, marked with L, there's been injury to a widespread area of the brain. And that's where the blood supply was interrupted at the time of birth. And this is right in the area of motor function. So it left Nicholas, not his real name, of course, with weakness in the right arm and leg and no fine finger movements. And you could tell by his walking that his leg was affected as well. And he had daily seizures, several a day, with sudden stiffening of the weaker right arm and leg. And when this happened, he would fall. So he was suffering from these seizures and he had no relief from treatment with many medications since 5 years of age. So when we met Nicholas, we knew that we were in trouble and we were asking ourselves, could surgery help? Now, just from this amount of information that we got in the clinic and the MRI, we saw that there really was an opportunity for surgery because we know that hemispherectomy can interrupt the seizure spread to the rest of the brain and the rest of the body and isolate that abnormal and malfunctioning hemisphere from the rest of the brain and the body and prevent the seizures from occurring. So looking at this, we already know things match up. The weakness is on the opposite side, which makes sense. The seizures are involving the side of the brain. The seizures are coming in the left, affecting the right side of the body. And we know that he doesn't have a good chance of ever getting good seizure control because of the way medicines haven't worked so far. So this, and we also know that if we remove this very damaged hemisphere or disconnect it, we're likely not to cause any serious new problems. Now, one thing that does happen with this kind of surgery, he had intact visual fields, and that would go. That would be an expected complication of a disconnective or anatomic hemispherectomy. We would expect him to have a blind side off to the right. And we would know that that's going to be the case, a hemianopia, and that would be part of the informed consent and conversation. Yeah. But if this surgery was successful, as we anticipated, then he has a very good chance of being completely seizure-free and maybe off medicines. Yeah. The wrinkle with him, his EEG was abnormal on one side, his MRI was abnormal on one side, but his EEG showed abnormalities everywhere. And for any of you who've watched the EEG monitors as things are being recorded, you might recognize that each of these wavy lines is from a spot on the brain. The left side is odd numbers, the right side is even numbers, so, and it falls out into groups of 4. So if you look at it, in the front of each of the groups of 4, there's a lot of activity going on that shouldn't be there. And it's on both sides. But we know that even if the EEG doesn't match up with the MRI, that is still compatible with the surgical plan. So we have to put that together with an understanding of how things work. But we know from experience that in Nicholas's case, the MRI was sufficient in the pre-surgical workup. The MRI, the seizure type, the side of weakness, all was a go for the disconnective hemispherectomy, even though the EEG was distracting us a little bit. But it's okay because we know that that can happen. And in fact, we felt the chance of stopping the seizures was about 75%. Now I'm going to show you a picture of what the MRI looked like after the surgery. And the thing I want you to appreciate, if you kind of look at this and look at his MRI, you see that that hemisphere has been rather extensively damaged. And if you look at the surgery afterwards, you can see there's still brain tissue in there. Yeah. the stroke area is still visible, and there's a little bit of an opening there in the middle of the hemisphere where the neurosurgeon went in to make an opening so that he could literally disconnect that brain from the other side and from the rest of the body. So it's almost like clipping some wires, if you will. It's clipping the fiber tracks that connect everything on the left to the rest of the brain and the rest of the body. And actually, anatomically, there's still plenty of tissue in there, but it just isn't hooked up, and it can't send its disruptive electricity anywhere. So it does have the chance of stopping everything. And in fact, with Nicholas, the result was fantastic. We have over 20 years of follow-up. He's never had a seizure since surgery. He's been off all his medications for many years, and his brain rhythms on the right are normal. And this is something that is relevant to what you were saying, Ms. Jones, is that if you have a constant barrage of electrical activity on the healthy side that's coming from the injured side, it is impairing the function of the good part of the brain. If you clean all that up and get rid of it, then the good part of the brain can do its good work. And having normal brain rhythms on the right allowed him to really gain a very positive trajectory in his development and activity. And he's independently living, employed, and I just saw him recently, and he's fantastic. So I'm very pleased for his outcome. And I think this illustrates how it does take courage to even think about surgery. It certainly takes courage to actually go through the process or to make the decision on behalf of your child. It is an agonizing decision. Yeah. But the goal is a much better life. And that's what we're trying to keep in our sights. Ms. Jones, would you like to comment on this case?
Just quickly about some of the research that we've done out of Caltech at the Brain Recovery Project. We evaluated several adults who had epilepsy surgery into childhood and had normal IQ. And it was really fascinating to see how that single hemisphere really, once the seizures stopped, was able to exploit its existing connections. And the MRIs were revealing the resting state, just how great these adults were doing just with one hemisphere. The hemisphere was doing the job of two in most cases, except for vision and except for hand use and that. But cognition-wise, very close to someone with two hemispheres. It's really fascinating.
It truly is. And I think what it reminds us is that when there's been a big stroke at birth, that hemisphere is not contributing much anyway, whether we disconnect it or not. It's already very damaged, and the function that does develop on the other side. And what that hemisphere, which is causing the seizures, is doing is it's impeding the work of the healthier side. It's making it harder for this person to develop to full potential. And that's why the earlier we do this kind of thing, the better, because you have more years of brain development. Adults also can have hemispherectomies for the same kind of problems that we do them in children, but we like to think of them as basically delayed hemispherectomies. In other words, for one reason or another, we didn't do it when we had an opportunity to do it. It's never too late, but we obviously want to move that timing down so that we can maximize development and well-being. Now, there are other MRI diagnoses, which you may have heard. One of the big ones is what we call a malformation of cortical development. And what that means is that one part of the brain formed incorrectly before birth. As you can imagine, brain formation is a very intricate and detailed process that occurs especially in the first trimester, but actually all the way through pregnancy. And if it doesn't go just according to plan, you can have things that don't work out exactly right. And this is an example. As you can see in this MRI, this is the same kind of view that you saw in the previous one, where the eyes would be in the front and the ears would be on each side. And the arrows are pointing to the right side. If you compare the right side to the left side, you will see that there are differences. It doesn't look quite right. So for example, on the healthy side, you see this very normal folding pattern we call sulcation. So this folding is very appropriate. Over here, it just sort of looks thick and not very folded or overly folded. Here you see this nice junction where the gray matter and the white matter are clearly delineated. And here you see it's sort of blurry and all kind of comes together. You also see what we call arborization, which means arbor meaning tree. So like the branches or the twigs of the tree, this is the white matter going on out into the cortex. You see how thoroughly that process occurs here, and yet over here you hardly see it at all. So, and in addition to that, this, we call that the ventricle, of course, as you know. That's the space deep inside the brain where fluid collects. That's a little expanded because there's some loss in the brain tissue on this side, so it expands up to fill the space. And here even too, a little bit less than there should be. So this whole hemisphere over here, the right side, has not formed correctly. And we know that when that happens, the electrical circuitry on that side of the brain can be very abnormal, and it can cause epilepsy, and is often very difficult to control. And you can also have those kind of subtle changes that are more localized. Here you can see that this is down in the inside of the left temporal lobe. We call this we use the word mesial, but it just means on the inside of the left temporal lobe, that this area doesn't look the way it should, either in its form or its what we call signal intensity. It's a little brighter on the MRI. And that is a clue that it did not form correctly. And both of these areas look like surgical opportunities. In this case, it would be a hemispherectomy, and in this case, it would be a temporal lobectomy. But the MRI really did tell us what to do here. And then you can also have non-serious early brain tumors. These are not brain tumors that are a threat to life, but they are findings which can cause abnormal circuitry in that area, and the seizures are the clue that it's there, and those can be removed. And the cases that I'm showing you here, fortunately, each one of these kids had a seizure-free result many years ago. And the MRI and what we learned in the office and on examination were the key features. The EEG didn't help as much, but it often does in other cases. The MRI was very powerful evidence in each of these cases, and the seizure stopped with surgery. Well, what if the MRI looks normal? And this leads me to another case that I'd like to discuss. Ms. Jones, do you have any comments or thoughts on the cases we've discussed so far, with very clear, where MRI really said X marks the spot, if you will?
No, I'm really looking forward to this next part about the MRI that looks good, because that comes up a lot in our community.
You are absolutely right. The MRI is so powerful that when it tells us what to do, everything is straightforward almost always. And when it doesn't tell us what to do, we are in a much more delicate situation. So you are absolutely right. Elliott. This little Elliott, of course, not his real name, precocious, outgoing 3.5-year-old boy, really a bright star. Seizures began at that age, and he'd started explosively right out of the box, 10 to 15 a day. The seizures seemed a little bit mild at first. He would have some unnatural laughter, turning of head, eyes, and upper body to the left for 30 seconds. That turning to the left makes us wonder about a starting point on the right side, as many of you will know. But it doesn't tell us exactly where on the right side. It just tells us probably focal, probably right side. And the seizures really were just very frequent, but at first not too terrible in terms of what they look like. But then it didn't take long. At 4 years of age, his seizures evolved and became much more severe. They involved sudden body stiffening, a forward fall. He was sustaining repeated facial injuries despite 24/7 supervision and helmet use. No relief with trials of 8 medications. And any of you who've been through this, you know that if your child is experiencing this kind of epilepsy, the entire family is completely involved in this. It's not just the child, it's everybody in the family, and often the extended family. This was truly a catastrophe for this family. The child was so perfect and now not. And the regression that occurred that Ms. Jones mentioned, where development just stopped and went backwards. You know, the language, he stopped talking, he stopped interacting, he lost eye contact, falling all the time. When I met him, he was wearing a helmet and had facial bruises and cuts. Just an agonizing situation, and medicines weren't helping. So we got the chance to meet him, and the first question was, okay, the MRI looks normal. Are we sure it really is normal? Our first goal is to look harder for the trouble spot on MRI, because the MRI is so precious and so valuable. If it tells us what to do, everything is so much more clear. And that was our first goal, was, okay, it's eluding us so far, but let's work harder on that. And then the second step was to seek supportive information from other tests. So this individual actually came to us from another country, as a matter of fact. So we tried to curate his stay in advance, and we just set up everything. We had all our testing available to try to get an answer because we knew that we were up against it. And the fact that it didn't look like he had a lesion on MRI, lesion meaning an abnormality, we were very concerned about finding it. So I'm going to show you this is a composite video of different tests that we did and how they're overlaid on each other in a 3D manner. And I'm going to start the recording a little bit. The first part of it takes a little while. I'm going to start it about here. So you can get your bearings. This is the right side of the brain: temporal lobe, frontal lobe, parietal lobe, occipital lobe. The motor cortex is in here. Language is on the other side, so we're not dealing with language. And now we're going to look at it cut like that. We call that coronal sections. And here's what I want you to notice right here. Do you see how crisp and normal that looks? Look at this, where there's a little teeny tiny tail. A little bit fuzzy compared to here. Look how sharp and round that is. Here it's, yes, and then when we looked at it in post-processing, that area lights up and says, look here, something's not right, in exactly the spot. When we did a PET scan, this is the normal metabolism, this is decreased metabolism. So it's not processing sugar the way it should. That's dysfunction. Just exactly the same area that we had looked at on the MRI and on the post-processing. You can see how healthy this is over here and how cold, we call this cold because it's literally not picking up the tracer. And this is what we call an ictal SPECT, where we injected a tracer and then later tested it with a special kind of, if you will, Geiger counter. And it showed that there was increased uptake right there in the same area because the seizure was starting and it used more blood flow during that time. So what we have here is a very subtle MRI abnormality. Just coming back to remind you, cutting through it here, you see this little thing right there. That is the whole story right there. Now you can understand why his MRI was read as normal. I mean, that you'd have to really be looking at it. Now, what happened was that he had had a lot of testing before, and there were some repeated, I'm going to use the word soft clues that made us be thinking about the right frontal lobe somewhere. And those were based on his seizure symptoms before they became so severe, and it was based on some subtle findings on his EEG, but then we lost those and they weren't there anymore. They weren't solid enough clues to do anything about it, but they were just a little suggestive, so that when we wanted to really get serious about imaging, we kind of knew the rough general location to focus on. So what we did was we planned in advance for a 3 Tesla magnet MRI that we gave complete full anesthesia, so the child couldn't possibly move at all and disrupt the testing. We do that, of course, with a board-certified pediatric anesthesiologist in attendance at all times. So this child was literally put to sleep lightly for the duration of the study, so there was no movement whatsoever. We used the 3T magnet, and then on top of that, we added a special, we call it a coil. We added special hardware to the machine, which gave 32 extra sensors right in here. We said, study this frontal lobe in great detail with a 32 channel coil. You know, we added a lot. In other words, we did everything we could to focus in on that. Those of you in the epilepsy community will also be aware that the 7 Tesla is much stronger magnet is being developed. Right now it's used for research purposes, and we use it at Cleveland Clinic for research purposes. It's not yet FDA approved for clinical purposes, but it will probably help us to find these in the future. But you see how subtle that is. You still have to kind of know where to look and what to look for. But the key thing is, this is a malformation of cortical development. So what happens is that when the brain is developing in the womb, this is the ventricle, as you know, this is that sac of fluid. Around the ventricle in the developing brain is a nerve cell factory. It's a brain cell factory, and it turns out billions of brain cells during the early brain development. And each of these brain cells travels along a little fiber to get out to where it belongs here. And then they build on top of each other from inside out like this. And when they're all where they should be, it's in 7-layer cortex. You can look at it under the microscope and you see all these cells lined up in a very irregular pattern. If something goes wrong with that trip, you can get the brain cells stranded in here. And they can be left, and that's why you get this lack of a crisp margin, because their brain cells scattered in among the white matter. And this trail illustrates that they got stranded on the way up. And we call this a depth of sulcus malformation. Remember, we talked about folding. The brain is all folded up. And of course, as you all know, the top of the fold is called the gyrus and the bottom is called the sulcus. And at the bottom of the fold, right in here, that is a very classic place for this stranding to occur. And this particular form of malformation is subtle to find on imaging, but it can be devastating in terms of the epilepsy. In other words, the size of the lesion, lesion meaning the finding on MRI, you can have a subtle abnormality on MRI, or you can have a dramatic abnormality on MRI, and that doesn't predict how serious the epilepsy will be. This is a highly problematic finding, even if it is so subtle. But the key thing is we found it, and it matched up with everything else. So all of a sudden, this family went from feeling hopeless and having no likely thought that anything was going to do any good to the next conversation we had was, okay, we found the problem. We know where the seizures are coming from. We know exactly the spot. We know it with very high confidence. And we know from lots of experience all over the world that if we do a very small resection and just get that out of there, the seizures are likely to go away more than 75% chance. So a normal MRI, if we think for other reasons there might be something possibly localized or meaning focal or spot, if there's a spot there and we just can't find it, the first thing we do is try harder to find it.
Yeah.
And converting a normal MRI to an MRI full of information is the most valuable thing we can do. So advances in technology are important. And so one of the first things to think about if you're thinking about getting epilepsy surgery or considering epilepsy surgery, and if everything isn't clear cut and straightforward and easy, then one of the first things you want to do is make sure you pick a center that has not only access to the technology, but has the kind of people around it with the experience and long history of doing this kind of work that they can find it and interpret it. Because as you can see, this could be something that anybody could easily skip over.
We hear that a lot, is the MRIs that look good, and then the family goes to a facility that has more experience. You know, they're known to be a large epilepsy center, and then that team catches the malformation right away. We actually have a family who will be speaking in our infantile spasms piece in a couple of weeks about this very same issue. One facility said, nope, no cortical dysplasia, sorry, there's nothing we can do. And another facility said, oh yeah, look, there it is right there, and you can have surgery. So,
and you know, people have said, you see what you know. So
yeah.
if you've personally cared for or been involved in the care of 30 other people with the same kind of MRI, and you've had a good experience with it, you get very sensitive to seeing it. Or some of, you know, our neuroradiologists, some of them have seen hundreds of cases like this. So you become more sensitized to it. It's only natural. We're all good at what we do every day. So it does make a big difference, because what the other team was talking about was putting subdural grids over the right frontal lobe. And that probably wouldn't have even found the problem, because the problem was so deep inside. And you really needed the MRI. I don't think that, you know, just putting electrodes in the brain may or may not solve your problem, in addition to sometimes adding a whole another layer of strategy. So if you look at this particular case, the MRI was subtle. This is the same case. It was subtle, but it was real. It's not that it's not a matter, it's really just about, is it there or is it not there? If it's there, then it's important. And yet look at the EEG on this child. By the time we met the child, the EEG was everywhere. The EEG was giving us no clues. So we would not have found this with invasive recording of either the depth electrodes or the subdural. It wouldn't have helped us because the EEG was already everywhere. We know that in children, that is a thing that can happen, is that little tiny things like this can cause chaos everywhere. And so finding the MRI was key. So I think, Ms. Jones, you bring out a very important point. You know, it's hard to be sure that you're getting the complete answer, but you do really want to make sure that that you're working with a team that's done a lot of this, because otherwise it's just too easy to miss this. You know, anybody could be forgiven for missing it, but it wouldn't be any good. And then we did the surgery, and look at his EEG.
Yeah.
Pre-op, post-op. So post-op, his EEG was completely normal. This was like 3 days after surgery. This was completely normal. All of that terrible activity evaporated. And this is what the family told us before they left and went back home to the other country. When he awoke the morning, I wrote this down verbatim. When he awoke the morning after surgery, it was as if he had matured 1 year and 1 day. Friends and family could even tell the difference just from photographs. His face looks bright again like it did before the seizure started. He's engaging in conversation, listening, and paying attention. We feel like we have our son back now for the first time since the seizures began. And that is because he was literally, we use this word epileptic encephalopathy, which simply means, encephalo means brain, opathy means problem or impairment. Basically, the brain function is being very much impaired by all of that electrical activity. And the only way you can get rid of it for some kids is to take out the trouble spot that's generating it in the first place. But if you do, then it's almost like a fog is lifted. And the children can participate and really come back into their own.
That's wonderful.
I know. Every time I think about this case, I get like a chill. And of course, you know, my gratitude is to be a part of a team that can make these miracles happen. You know, nobody can do this on their own. You've got to have the radiologists, the team that does the anesthesia, the surgeons, your colleagues who help you interpret things. You know, it really takes a collaboration between so many people, and to be a part of that kind of a team has been my greatest honor in medicine, is, you know, to be able to do these kind of things together. And, you know, I guess my message that I would like to share with you is that epilepsy surgery is not a last resort. It's an opportunity for a better life. If medicines are not solving the problem, and we're looking at a lifetime that looks just like it does today with lots of seizures and developmental issues and drugs and repeated emergencies, if we can see a surgical way forward, it's an opportunity to really change the equation. And so that's why I'm so honored and pleased that Ms. Jones gave us the opportunity to present some of this experience to you. Thank you.
Thank you so much. We're working very hard to break down those barriers so that parents have the opportunity to make informed healthcare decisions for their kids, and they can't do that if they don't know about a treatment option. Thank you.